Hello, welcome everyone. Welcome everyone to tonight's Nordocs webinar on common shoulder problems. My name is Peter Silverberg. I'm a GP. I work in Lennox Head and Lismore, and I'll be your presenter for tonight's webinar. I'd like to start with the Acknowledgement of Country. I'd like to acknowledge the traditional owners of the land which we meet today on the Bundjalung Nation, and pay my respects to elders past and present and emerging, and to any Aboriginal people attending tonight's event. The Bundjalung Nation extends from Grafton to the Clarence River, to the Logan River in the north, and inland as far as the Great Dividing Range at Tenterfield. A reminder that Nordocs is a network of all doctors, including GPs, specialists, doctors in training and medical students, living or working in our geographical footprint that extends from the Queensland border to Grafton. And one of Nordocs' aims is to support all its members by improving the health of the North Coast community. Education is a big part of this process, including these webinars. It also includes our flagship quarterly magazine and maybe sometime soon, maybe a return to face-to-face education. A quick thank you to our sponsors tonight, St Vincent's Hospital in Lismore. Nordocs is a not-for-profit organisation and relies on sponsorship to run these education activities for its members. Okay, moving right into the session. So I'd like to welcome Dr. Shane Prodger. Evening, Shane.
Good evening. How are you, Pete?
Good, thanks, mate. So some of you may know Shane. For those of you who don't, he's an orthopaedic surgeon and he works both in the private and public sector in Lismore. And maybe just as a way for us to get to know you a little bit better, Shane, I thought I'd just ask you a few quick questions before we get going.
That sounds good.
That sounds good. So tell us a little bit about your journey to living on the North Coast.
It's been a journey to get back to the North Coast. I grew up around here. I went to school in Lismore, and once I finished school, I went to Brisbane and studied physio, and then worked as a physio for around 4 years. I wanted to do medicine when I left school, so that thought never really left my head. I went back and started medicine in Queensland. Once I finished that, I did my junior years and then my training years in southeast Queensland. But the plan was always to come back here at some stage, and that opportunity arose, fortunately, when our kids were still really young, so we could come back and I could start work here, and the kids started school here pretty much. Yeah, it's been a good move.
True local lad.
Yeah.
Yeah, that's great. So, and you mentioned you wanted to do medicine from early on. What about being an orthopaedic surgeon? What brought you to that specialty?
Yeah, that wasn't really the plan. When I finished medicine, I really liked medicine, I really liked emergency work. But as I got sort of through junior years, I did more surgical terms, not by good management, just more by luck and how it played out. And I realised that I wanted to do some surgical specialty, and orthopaedics appealed the most to me.
Fantastic. And so you're working in Lismore now?
Yeah, that's right. Yep.
So
I work in Lismore at the base and St Vincent's, and see patients in Ballina and Lismore.
Okay, fantastic. And your scope of practice in orthopaedics, do you have a particular joint that you like to work on, or you're open to different referrals?
So probably 50% of my workload is knees, probably 30% is shoulders, and then the rest is a mix of trauma when I'm on call at the base, hip arthritis, and then the occasional sort of simple hand or foot referral. But it's largely knees and shoulders is the bulk of my practice. Yeah, and that's certainly what I enjoy the most.
So if you've got any questions for Shane as we move along in tonight's event, you'll notice at the bottom of your screen that there'll be a chat box. And if you put a question in that chat box, then I'll endeavour to get to that as we move through the event tonight. So we want this to be interactive. So if something comes up as we move through the cases, then just put a message in there and I'll just get to it. So starting off with what we're going to cover tonight. So we really hope to cover, many of the major common shoulder disorders that you're going to see in general practice, and by the end of the event to feel more confident in managing these and understand what some referral pathways are, whether they be public or private. So these are the four common shoulder illnesses that Shane's elected to talk about tonight. And Shane, we were just joking before that if you should be able to make a diagnosis by the end of your history. So that's a good place to start and hand it over to you, my friend.
All right, thanks very much, Pete. Good evening, everyone. Thanks for joining us. After each of those topics, I'm very keen to take questions or comments. Shoulder pain is about 30% of my practice, and those four topics would make up, well over 90% of the pathology. Occasionally, there's something unusual, but most of the problems fall into those four categories we'll talk about. Pete's right, and everyone knows that a history really guides where you go with investigations and where to start treatment. And most shoulder problems can be treated without surgery. In broad terms, probably 30 to 40% of the patients that I see with all pathology end up with an operation. So most of the patients I see are also managed non-operatively. The things that this is just a broad list. The things I focus on are the goals of treatment, and that's largely determined by how old the patient is, and if they're working, what job they do, what sports they want to get back to, and whether it's actually coming from the shoulder. There's really no shoulder pathology that refers pain below the elbow, and certainly any neurological symptoms distal to the elbow won't be attributable to local shoulder pathology. It doesn't mean the patient won't have a problem with their shoulder as well, but sometimes it's just setting realistic expectations of what can be offered with treatment of their shoulder pathology. And look, pain is what most people come to you as well as me, and it's how to best relieve their pain. The physical exam is the same as what we all learn at medical school and through all of our training. The musculoskeletal exam is look, feel, move. The photo on the left is a pretty typical appearance of someone who's ruptured their long-headed biceps. This is really common, and it's not treated with an operation. In fact, there's lots of operations, some of which I'll talk about, where the long-headed biceps is cut intentionally, and in fact that may be the whole operation to deal with some shoulder pathology. That's not a problem in itself. Muscle wasting usually occurs either in a neurological condition or in an acute massive cuff tear. Someone with an old cuff tear won't get muscle wasting in the supraspinous or infraspinous fossa. The photo on the right's more just out of interest. It's someone with a long thoracic nerve palsy. So, we'll go through this slide quickly. Feel is the next part of the examination. And then if we go on to the next slide, move. External rotation gives a real clue to what's going on. I'll mention it in another slide, but there's only three things that will stop someone from externally rotating their shoulder, like in this picture. So in their left shoulder, that looks largely normal, but on the right, it's reduced. And the only pathology that can cause that is either osteoarthritis, a dislocated shoulder, or a frozen shoulder. And most people don't walk into our rooms with a dislocated shoulder, so it's only going to be frozen shoulder or arthritis in that setting. So if we move on to rotator cuff tears, I've tried to summarize this, but it's a difficult problem, and all surgeons try and pick the winners with surgery, but this is a pathology which is difficult to know what to do in many patients, actually. Rotator cuff tears cause pain, plus or minus weakness. As we get older, the cuff starts to fail without trauma. And that's largely independent of the type of work that we've done. Manual workers are more predisposed, but even sedentary workers, the cuff fails as time passes. So 40% of 60-year-olds who have an ultrasound of their shoulder will have a full thickness cuff tear, and 70% of 70-year-olds who have an ultrasound of their shoulder will have a cuff tear. So I hope that makes sense. So an asymptomatic shoulder in a 70-year-old, if they present for an ultrasound, there's a 70% chance they'll have a cuff tear, even though there's absolutely no symptoms.
So that's a fully functioning shoulder.
Yeah, correct. Yeah, correct. So if a 70-year-old turns up to the rooms with a sore shoulder and they have an ultrasound and it shows a cuff tear, if they have an ultrasound on the same day of their asymptomatic shoulder, there's a 70% chance they'll have a cuff tear there as well. Yep.
So I guess without stealing the thunder with this slide, you're probably going to get to it, but I guess the next question beckons is, can an ultrasound tell you whether it's an acute or an old tear?
Yeah, that's a good question. And the short answer, the short answer is no, but there are some clues from the size of the cuff tear. Yeah. So I think, and I'm happy to lead into that point now, actually. That's a good question. X-rays are really important. A lot of patients present to my rooms with just an ultrasound. But an ultrasound and an X-ray for most pathology for me go hand in hand. If someone has a large if an elderly patient, for example, has a large cuff tear, then an X-ray will tell us if that is chronic, if the X-ray shows arthritis in the shoulder. If they've got a pristine X-ray with a large cuff tear, then maybe it is something new and that changes their treatment options. An MRI scan's really the best way to see if it's a chronic cuff tear. That picture with the little white circle is the sagittal image of the cuff. The Y-shaped structure in the center is the scapula, and where that little white circle is a really atrophic supraspinatus. So that the supraspinous fossa there should be full of muscle, which is black on that sequence. But on this picture, it's full of white, which is fat. So that supraspinatus is really atrophic, and that tells me that the cuff tear is really old, like years and years old. You can see the subscapularis on the lower left-hand side, which looks normal, and infraspinatus on the lower right-hand side looks really atrophic as well. So an ultrasound and an X-ray is a good start. Not if you think someone's got a cuff tear, an ultrasound plus an X-ray is definitely the way to go. And then an MRI, if they end up with me, will say whether it's an old or a new tear.
So can I just pause on that point for a second, Shane? Because I suspect a lot of people don't do the plain X-ray.
It's really helpful. And that if someone gets a referral, if I get a referral of almost any patient with just an ultrasound, they all get sent for an X-ray before I see them.
And the main reason for that is to see underlying osteoarthritis. Is that correct?
Yeah, correct. Yeah, if there's an elderly patient with a big cuff tear on an ultrasound, then there's a fair chance they'll have degenerative changes on their X-ray, which I'll talk about more in the shoulder arthritis. But yeah, an X-ray is really important. It's very helpful.
Yeah. Okay.
The management of cuff pathology is usually non-operative in the first instance. Certainly if there's just tendonitis or small partial thickness tears. That's a really common finding on an ultrasound, is the comment of a partial thickness tear. There's largely no indication to try and fix that in the first instance, even in a young patient. The treatment would be physio, anti-inflammatories, activity modification, and a steroid injection. It's full thickness tears where it can get a little bit more difficult to work out whether someone needs an operation. Maybe to go to the next slide.
So, sorry, just before you go there, we just had a question.
Yep.
Someone's wondering about the goal of physio and cuff tears. So,
Yep.
If we won't be able to actually repair the tear, I mean, obviously a physio can't repair a tear, can they? You've got a lot of scarring to have in by itself to do that. Is the role there, is it to strengthen the muscles around the joint? Is it for pain relief? Is it to maintain function of the joint? What is the role of the physio while a rotator cuff is repairing itself?
So in partial thickness tears, if they're traumatic, if there's a clear mechanism in a young patient, for example, and it's just a partial thickness tear, then that's still got the potential to heal. The cuff's really vascular in young patients under 50. So a partial thickness tear has got the potential to heal. And physio helps retrain the remainder of the cuff, and retraining the deltoid to accommodate for any cuff weakness is really important as well. So it's largely, muscle retraining, making sure scapular stability and the biomechanics of the shoulder is maximised, and pain relief's largely the domain of anti-inflammatory drugs or an injection. Yeah.
Yeah, well, I guess that would be the next question, is the role of the steroid injection. So correct me if I'm wrong here, but my understanding of what I've told patients is the steroid injection is not going to get you better faster. It's just a pain relief while your body's getting better by itself. Is that sort of correct?
Yeah, I think that's a good way of putting it. Yeah, absolutely. It takes inflammation out of the bursa, and that's largely it, which will ideally help their pain. And an injection's good too for diagnostic reasons. It'll tell you, the patient, if that is the source of their pain. So it's therapeutic and diagnostic. I think injections are really important. Yep, and early on.
What do you tell a patient if you do the injection yourself, or you refer them?
I do it myself actually, unless they're they've got, if they're really overweight and they've got a huge soft tissue envelope, for example, I'd get an ultrasound guided injection. But I do most of them.
And what's your little spiel you give a patient about having a steroid injection, education about afterwards and whatnot?
I tell them that there are two reasons why I'm doing it: to see if this is the source of their pain, and if it helps their pain, even if it's for a brief period of time, then we know that they're the structures that are generating their pain, that being the bursa and plus or minus the cuff tear. Most patients get good pain relief for weeks to months, and it allows them, and I tell the patients it allows them to engage in meaningful rehab with their physio.
Does the injection have to actually go in the bursa, Shane, or is it just in the subacromial space?
Just the subacromial space. Yeah, the bursa is it's not a discrete structure. When you put a camera in someone's subacromial space with bursitis, it looks like sort of cobwebs everywhere. It's not something you can identify as a discrete anatomical structure.
So all those pictures, like the one you showed us, where you see like a little sort of pouch of fluid.
Yeah, it's not like that at all. No.
Amazing.
So if you just if the needle goes in the subacromial space, it will definitely go in and around the bursa. Yeah.
Right. So I mean, you're doing it yourself. I mean, what I tell patients is like you. I say, if you want to move your shoulder immediately afterwards with a local anaesthetic to see if you can get above your shoulder without pain, that's helpful to see as a diagnosis. Yeah. But don't keep doing that, because you'll hurt yourself. Do it once and that's enough. Yeah. And then I often warn them there might be pain for the first few days, because their steroid can be irritating to the joint.
Yeah.
Maximal effect is normally around about 2 weeks.
I think that's a fair comment. Yeah, the local is immediate, and the steroid takes days to a week or two. Yeah.
Yeah. Yeah. And then someone wants to know how many you're allowed to do and how far apart, and if the first one doesn't work, you do another one, or...
Yeah, and that's a good question, and I haven't got a great answer for that. If it's someone who is definitely not going to have an operation, like an elderly patient with a chronic cuff tear, with pain and reasonable movement, I offer to do an injection every 4 to 6 months for them. If that's part of their management, their ongoing management, they're never going to have an operation. That's a good, and if that works for pain relief for them, they can have many over time. I think if someone's got impingement and they have 2 injections over a period of 3 to 6 months and they're really not winning, then there's probably not a lot of utility in continuing that. But if someone, has an injection, it gives them 12 months of relief, and they come back and say this pain's come back, then, it's worth trying again. I haven't got a great answer for that, but broadly it would be 2 or 3 over a period of a year or so. Yeah.
Great.
So if someone's got a clear mechanism of injury, a young manual worker that has a fall or something falls and they try and catch it and they experience immediate shoulder pain and they have an ultrasound or an MRI which shows a cuff tear, then all things being equal, they should have that fixed surgically. There's really not a lot of point waiting to fix an acute tear in someone who's young and healthy. And young's a bit of a nebulous term, but I would put that as someone sort of under 55 with no medical comorbidities.
You're talking full thickness tear?
Yeah, full thickness tears. Yeah, yep. Full thickness tear. Yeah, and if someone like that comes to me, I get an MRI, so I'm convinced that that's the right thing to do. But if there's a cuff tear on a full thickness cuff tear on an ultrasound, that's quite a sensitive test, but often it doesn't quite get the size right. I've put that down the bottom actually. Yeah, so if an ultrasound's normal, there's probably no tear. If an ultrasound shows a tear, then there probably is a tear, but the size of the tear may be undercalled. And an MRI helps define whether that cuff tear is acute or chronic. If there's a full thickness cuff tear that's 10 to 30 millimeters, that's medium, but it's getting medium to large, and I'd definitely fix that. If there's a small full thickness cuff tear in someone who's young and healthy and there's a clear mechanism, I think that's still reasonable to fix that too.
And how quickly do you need to see them?
Oh, it's nice to see them, within weeks, to plan to fix it within weeks. There's actually no super urgency, Pete. It's not like it gets harder as time passes, but these are the patients that would benefit from surgery, and there's no reason to wait. They can start their rehab and start their plan to return to work.
Yep.
We know that patients who are older, so over 65, high BMI, smokers, diabetics on anticoagulants do poorly with cuff repairs, and probably somewhere between 40 and 70% of those repairs fail. Some patients still get a good result in regards to pain relief because they've had they've taken away any subacromial spurs. Maybe cleaning up the edge of the cuff tear makes it slightly more comfortable, but in broad terms, those patients aren't real winners for that sort of surgery. There's no difference in patient-reported outcomes, whether it's open or arthroscopic. Lots of my colleagues now, including myself, who tried arthroscopic repair for a few years, just do a small open incision. The procedure goes quicker. You can see the whole cuff, and the outcome's exactly the same. Steroid injections we touched on. I think if it's a young healthy person with an acute cuff tear, there's no real utility in injecting it with a steroid. There's no evidence for PRP injections in cuff tears.
Yeah, that's great, Shane. And that first point about who gets poor outcomes made sense to me the other day when someone explained it in terms of, like you've said, thinking about the vascularity of the cuff. So if you just think about all those things, decreased vascularity, diabetes, smoking,
Yeah.
you know, age. That's why they do worse, I imagine. Apart from all the
Yeah.
other comorbidities along with that illness, but
Yeah. That's exactly right. Yeah. And that's where getting an ultrasound in someone who's 75 with a sore shoulder, that can create some confusion with the patient. I'm not saying it's the wrong test or it shouldn't be done, but they see the report or they get relayed the report, you've got a big cuff tear, maybe you need this fixed. If they're probably what they need is physio and some injections and time, and it'll just settle down to be acceptable.
That's great. So we're going to move on to frozen shoulders. We've had quite a few questions I've asked you have been from the attendees, Shane. So
Yeah.
if you got more questions about cuff tears, you can still put them up there. But let's move into the second topic.
Thank you. I'll try and ignore my phone. I'm just on call and there's a couple of minor things, so it's all good. So frozen shoulder, I get a number of referrals for frozen shoulder, and that's fine. I like seeing these patients, but they're difficult patients for everyone because it's hard to know what to do. Well, it's not hard to know what to do. What to do is to do nothing, but that's hard for patients to hear when when they're in a lot of pain and they can't work, they can't sleep, etc. So the pain is usually present for months. Then after a few months, the stiffness sets in, and then the stiffness goes, the pain goes, and they're just left with stiffness. Females over 50 is the demographic. There's a whole bunch of risk factors, immobility even after minor trauma, diabetes, thyroid disease. Up to 10% of patients will get a frozen shoulder after cuff surgery or breast cancer surgery. The pathophysiology is not completely understood. It's thought that it's not dissimilar to Dupuytren's in the sense that supportive cells change their function into contractile cells, and they cause this retraction or tightness around the capsule. They're not, Dupuytren's and frozen shoulder aren't in any way related, but at a cellular level, it's a similar sort of process. Limited movement, external rotation is the giveaway. They come in stuck at sort of 0 degrees of external rotation. And if they've got a normal x-ray and they can't externally rotate their shoulder, then the only thing it can be is a frozen shoulder. We talked about the three phases. Each phase lasts from 3 to 6 months. An x-ray to exclude arthritis. It's a clinical diagnosis. There's not a lot of utility in getting an MRI scan. Some radiology reports say that the patient's got adhesive capsulitis when they've definitely not got that. So I'd struggle to see what the radiologists look for in an MRI, but largely there's not a lot of point getting an MRI if someone's got a frozen shoulder. Almost everyone gets better. I say to my patients that 95% of patients get 95% better. Some still have some residual stiffness into flexion and external rotation with no functional limitations. And largely the management's around pain control, gentle movement with hydrotherapy or physiotherapy, guided exercise treatment. But getting a physio to sort of jump on the shoulder and try and stretch it out, the patient usually doesn't go back for many sessions of that. So corticosteroids, a short course may be appropriate. Non-steroidal anti-inflammatories are good. There's no role for opiates. Glenohumeral joint steroid injection under ultrasound guidance is a good idea. It's a good way to manage people's pain, particularly early on in the course. And there's some evidence to say that it may shorten the natural history of the frozen shoulder. Ultrasound guided hydrodistension the evidence says there's no difference and it's just as good or otherwise as a steroid injection. In saying that, if a steroid injection, if someone's in the first stage or the second stage, which is usually when I see them, that pain and stiffness stage, I'd send them for a steroid injection in the first instance. If that helps, but the pain comes back, I often send them for a second injection 6 to 8 weeks later. If that doesn't work, I would then send them for hydrodistension. I think it's worth trying all of these modalities. At 12 months, to be honest, I wait longer than that, but the evidence said if there's significant stiffness at 12 months, then a manipulation is a good idea. And if there's pain and stiffness, they may benefit from an arthroscopic capsular release. The photo on the right, I should have put a normal one up next to it, but that red tissue is really inflamed, injected synovitic capsule. That white structure sort of running horizontally across the middle is the long-headed biceps. The humeral head's on the left, the glenoid's on the right. So an arthroscopic capsular release, which is something I would rarely do because most people get better, is largely just dividing the capsule along these, between the interval between the tendons. And that causes pain then in itself. But if you do the capsular release and a manipulation at the same time, most people get benefit out of that. That's not common. That's not a common approach. 95% of people get better without going near an operation. Yeah.
Yeah. So when you say the Ghj steroid injection, you're talking about just still a subacromial joint injection, or it's got to be in a different space?
It needs to be in the glenohumeral joint, yeah. So that in that instance, I would send them for an ultrasound guided injection into the glenohumeral joint, not the subacromial space.
So if you write steroid injection shoulder, frozen shoulder,
yeah,
would the radiology guys know to go in the Ghj joint, or you've got to actually specify it?
Yeah, I specify it on the referral because sometimes not. The patient ends up getting an injection into the subacromial space. Yeah.
Yep.
So yeah, I'll write injection into the glenohumeral joint. Yeah.
And the ultrasound guided hydrodistension, can you do that locally?
Yep. So the radiologists at North Coast Radiology do it. Yep.
I'll do that. Okay, sure.
Yeah. Yep.
Okay, and then from the attendees, just going back to the PRP, I don't know if you know the answer to this, but there's a question here: is there evidence for PRP in any joint? Because there's some concern about risks.
That is a good question, actually. There is evidence that PRP can provide prolonged pain relief in mild and moderate knee osteoarthritis. So around 80% of patients will get good to excellent pain relief in early knee arthritis with PRP. So they're the patients that I send for PRP injections. Is the 45 to whatever 60-year-old with early degenerative joint disease that can still do most things but not everything. I think they get good benefit out of PRP, and that often delays surgery for years.
And where do you send them for that?
I send them to a sports physician on the coast called Dion Lewis. Dion seems like a nice, sensible chap. I don't know him personally, but he's always amenable to seeing patients, and he seems to give good broad advice around non-operative management of knee arthritis in that situation. But there's good evidence that PRP is helpful in tendinopathy. So, tennis elbow, those sort of problems. So I send him those sort of patients too.
Okay.
Yeah.
So our good old friends who do acupuncture, any evidence for acupuncture and frozen shoulder that you know about?
Not that I know of, but I really encourage my patients to explore all non-operative options. So some people love acupuncture in a frozen shoulder, some people hate it. Some love massage, some don't. Any non-operative treatment that they want to pursue, I would encourage.
Yeah, whatever works. Okay.
Whatever works. Yeah.
And another one person has asked: is there any residual loss of movement at about 2 years with frozen shoulder?
If there is, it would be, it should be minimal. 95% of people get 95% better. So often people lose 10 degrees of flexion and external rotation. That's not, that I see that on not infrequently, but it shouldn't be a significant loss of range of motion. It shouldn't cause any functional problems. And if that's the case after 2 years, then maybe they need some intervention or maybe something else is going on.
Great. Oh, that's really helpful. So 2 things I learned there: 95% get 95% better.
Yeah.
And the Ghj steroid injection early in the course. I hadn't been doing that in frozen shoulder, so I'll definitely add that to my toolbox. Okay, so moving on.
So shoulder arthritis tends to present in 60-year-olds. It's more common in women. If a young person has a shoulder dislocation, there's a 50% chance that 25 years later they're going to have arthritis in that shoulder. Stiffness into external rotation, all the other sort of classic symptoms of an arthritic joint. No evidence for PRP, hyaluronic acid in shoulder, osteoarthritis, and the first port of call for almost everyone is non-operative management. So
just clinically, when they're in your room, distinguishing someone's got poor external rotation and you're working out, is it arthritis, is it frozen shoulder?
Yeah.
Can you just give us a minute breakdown on how you do that?
Yeah, so shoulder arthritis is often preceded by trauma or surgery. Frozen shoulder has, and it's usually a pretty slow burn. So arthritis is a pretty slow burn. So they'll notice the stiffness come on really slowly over a period of years and years and years. A frozen shoulder tends to happen in really discrete stages. They have got pain for a while, but then all of a sudden over a period of weeks, their shoulder becomes really stiff and they can't flex it or externally rotate it. And in broad terms, the pain in a frozen shoulder seems much worse than an arthritic shoulder.
And the range of movement, because I always thought frozen shoulder had been a capsular thing. It's like I always think about it when they can't move their arm in all the different ranges. It's external, abduction, flexion.
Yeah.
You get the same in arthritis, or it depends on how advanced it is?
It depends on how advanced it is, but a lot of people still have reasonable flexion in arthritis, to 120, 130 degrees. They just can't externally or internally rotate their shoulder. It tends to be just a slower, gradual onset with arthritis.
Yeah. Great. Excellent. That's good. Thank you.
That's fine. Next slide's good. So osteoarthritis is, when one's considering surgery, largely boils down to A, they've failed non-operative management, and B, whether they have a functioning rotator cuff. Although the thoughts about that are changing, which I'll outline on a slide in a moment. So if someone's got osteoarthritis with a functioning cuff, and that's determined largely by radiology, whether that's an ultrasound in the first instance, but ultimately always an MRI scan. If they've got an intact cuff, then they can have an anatomic shoulder replacement, which is just what it sounds like, which is a stem with a ball on it on the humeral side, and a plastic glenoid. On that photo on the right, it's a little hard to see, but in the mid part of the hemisphere of the ball is a little horizontal white line, which is a metal marker inside the glenoid plastic insert. It's an excellent operation for pain relief. Most people get almost hip replacement type pain relief very quickly, but it's a slow burn with their rehab. You've got to take off subscapularis to get into the shoulder, and then that needs to heal, which is sort of 6 weeks of limited external rotation and a pretty slow progression towards flexion over a few months. But it's a good operation to help pain. People can't go back to heavy manual work. So if this patient, for example, was a 55-year-old plasterer who needed to work for another 10 years, and a shoulder replacement's no good because it's not going to meet their functional demands.
So what's the TSR stand for?
Total shoulder replacement,
Oh,
sorry.
total shoulder replacement.
Yeah.
So what someone's asking, what sort of range of movement are you expecting after a total shoulder replacement?
Yeah, most patients get around 150 to 160 degrees of flexion, 30 to 40 degrees of external rotation, and you try and set the implant or position the components so they can get their hand behind their back for personal hygiene and dressing, etc.
Wow, so it's really so it's pain relief and sort of functions of ADLs. It's not really going to get you back into a high functioning musculoskeletal type job.
Work down around chest height and below is okay, but heavy manual work above shoulder height's really difficult, and it's not a great long-term solution. It's better to try and manage those manual workers with non-operative means until they're getting towards the end of their career.
Yeah.
But I've got a guy who a patient who is in his 50s who had severe arthritis of both shoulders, and he works in a bar and trucks around kegs all day, and he can manage that with shoulder replacements because the heavy work is at waist height. It's not above his head. But yeah, heavy manual overhead work and shoulder replacements tend not to go together real well.
And are we doing them publicly?
Yep. Yeah. So Luke Henschke, John Myson, and I do public shoulder replacements.
Yep. Great. Good. Okay.
The other type of shoulder arthritis is called cuff tear arthropathy. So these are the patients with massive chronic cuff tears, and over time the humeral head migrates superiorly. And you can see on the X-ray on the left, the humeral head is almost articulating with the acromion. You can sort of use your mind's eye to see that humeral head should be inferior, about 10 to 15 mils. The ball's not lining up with the socket. So that this happens when there's a huge cuff tear, and over time the articular cartilage of the humeral head wears away because it's articulating on the acromion. These patients often come in with progressive loss of range of motion and pain, but some will come in after really minor trauma, like a bit of a fall, and they land awkwardly on their shoulder, and all of a sudden they've got largely no movement in their shoulder. They have an ultrasound that shows a huge cuff tear, and the immediate thought, understandably, is they've had an acute large cuff tear, but an X-ray is helpful, because if the X-ray looks like that, it's not an acute cuff tear. It's just the trauma has sort of, been the straw that broke the camel's back. So a reverse shoulder replacement is just what the photo shows. The ball and the socket have been flipped around. So the ball is on the glenoid and the socket is on the end of the stem. It's an ingenious piece of engineering. This concept's been around for about 50 years, but it was in the late 80s when someone called Grammont took the bull by the horns and spent lots of time trying to perfect the design of this, and largely allows the deltoid to accommodate for an incompetent cuff. And these people who recover well, and most do, go from being able to barely move their arm to flexing it to 160 degrees, within weeks of this operation. So excluding complications, this is a great operation for people with arthritis and an incompetent cuff. And that operation is becoming much more popular for a whole bunch of reasons. So just for completeness, Hemi Arthroplasty, which is just taking the ball out, doing nothing to the glenoid, nothing to the cuff, is largely an historical operation now. It used to be the mainstay of treatment for shoulder arthritis decades ago, but there's really limited indications for that because the outcomes are just routinely so poor. There's some indications to just replace the ball, but they're few and far between. A reverse shoulder replacement is reliable, reproducible. It gives largely good results in people with no cuff, and shoulder arthritis, and it can be used in fractures as well. So an older person who has a fall and blows their humeral head apart, in the past would get a Hemi Arthroplasty and have minimal pain but not much movement, or you'd try and piece it back together and plate it, and they would routinely do poorly with function. But now you just take the busted ball out and put a reverse shoulder replacement in, and within 6 weeks, most are doing very well. That graph is from the Australian Joint Registry, and you can see that 10 years ago, it was about a 50-50 split between anatomic shoulder replacements and reverse shoulder replacements, but now it's 80% of shoulder replacements are reverse shoulder replacements. So some surgeons don't even worry about the cuff. In arthritic shoulders, they just plan to do a reverse shoulder replacement, regardless of whether the cuff is good or bad. Most, including myself, are selective, and young healthy patients with arthritis and a good cuff get an anatomic style shoulder replacement. Does that make sense?
Yeah, that makes sense. Yeah. So we've got 15 minutes left, Shane, just to let you know.
Yeah, great. Sorry,
Yep. So just a question from the floor. Are there any big complications that GPs should look out for after a TSR or reverse TSR?
Yeah, so, infection is still, and again, the worst complication after a joint replacement. If there's wound problems, then it's the same as a hip and a knee replacement. The treatment's not antibiotics. It's to let the surgeon know, get a review as quickly as possible, and see whether, determine whether it's superficial or deep and needs, surgical intervention. Yeah. The other complications which are quite devastating, but fortunately rare, are nerve damage. So axillary nerve damage in a shoulder replacement's about 2%. And if that gets damaged and doesn't recover, then it's a disaster. Musculoskeletal nerve damage is also rare. It would be less than 1%, but infection and nerve damage around the shoulder replacement would be the worst complications.
Great, thank you.
I'm happy to go through this a little quicker, actually. So shoulder instability, we can go to the next slide, is okay. Reduction is usually or almost always in ED or out on the sports field. That's not something that happens in our rooms. Immobilisation after first time or after a shoulder dislocation, particularly the first time, should be really brief, days to up to a week, but not weeks. Anywhere between 3 and 10 days is more than enough. The longer they're in a sling, the stiffer it's going to get. An X-ray usually happens in the emergency department. 80% of patients over 60 who have a shoulder dislocation will have a cuff tear as well. So if an older patient particularly comes through your rooms after a shoulder dislocation that's reduced in ED, complaining of ongoing pain and weakness around the shoulder, then an ultrasound is a really good idea in the first instance. So referrals should be made. The irreducible shoulder dislocation is largely ED referrals to when the patient's going to come into hospital. More than 5 dislocations, it starts to really dust up the glenoid, and that can change the surgical options for the patient. If there's a complication like a fracture, nerve palsy, cuff tear we touched on. First time dislocations is the area that causes some thought about who should have surgery. If someone's young, if it's a young male or female who plays contact sports, there's a 90% chance of recurrent instability. So if they want to keep playing that sport, they should have something done straight away instead of playing for another year and coming in with, being referred when they've had 5 or 6 dislocations. Ongoing pain despite physio and time, one would consider surgery, but largely it's the young sporting person that's going to be a candidate for an operation quickly. First time dislocation, the surgical it's recommended that 14 to 30-year-olds have a stabilization procedure after one dislocation if they're going to stay in the same sport. Early review is good, so that the discussion can start, and the sooner it's stabilized with surgery, the easier the operation, no doubt. Complication rates lower, and they probably have better outcomes long term.
So what happens with young people in the public system who present to ED? Are they getting referred into the orthopedic outpatients?
They often get referred to fracture clinic, and they'll be seen by Luke Henschke or Herwig Drobetz. Or, if I get a referral for a young person with a first-time dislocation, I try and see them, within a month or so, and just give them the options. And some will say, no, I definitely don't want surgery. I want to try and finish the season, whatever. And all of that's fine. And to be fair, that's what most do. They want to try and give it a crack and see if they can get a bit longer. But
until they have their second one.
Once it happens the second time, they usually come around pretty quickly. So a Bankart repair is the Bankart lesions when the glenoid peels away from the labrum, which is that top left photo. That little star is on the glenoid, and that white frayed tissue above it is the labrum, which should be stuck back down onto the bone. Arthroscopic stabilization is a good option for most. It's a reproducible operation. Surgical time's probably less than an open procedure. And you're in the shoulder, so you can see if there's other labral tears that need to be addressed, or if there's chondral pathology that needs to be addressed. And the bottom right photo is showing some sutures with that labrum stuck back down. An open repair is needed if there's a fracture that needs to be fixed as well, or if the arthroscopic procedure's failed. You can do some other things, which are on the next slide. So if an arthroscopic procedure fails, then the next step is called a Ghj procedure, which is moving the coracoid from where it is, and you cut it off with the conjoint tendon and plug it into the front of the glenoid. Sometimes an arthroscopic stabilization is not appropriate. If there's been bone loss off the glenoid, then this procedure needs to be done straight up. And some particular sports, like I've had a couple of rodeo riders for whatever reason in the last year, and they've got this operation because it probably confers a little bit more stability with those extreme type sports. So look, they're the take-home points, which was sort of covered over the talk.
Oh, that's great, Shane. Really good. So we're going to go into this ask you anything. It's called Ask Me Anything, but don't ask me. We're going to ask Shane. So call it Ask You Anything. So we've got a question here. So does an indentation or a minor fracture of the humeral head in the case of the dislocation have any clinical significance?
Not really. So that when the humeral, and this is all just talking about anterior shoulder dislocation, which is over 90% of dislocations. When the humeral head comes out the front, the back of the humeral head bangs on the front of the glenoid, and it creates a dint called a Hill-Sachs lesion. If that Hill-Sachs lesion occupies more than 25% of the head, then that is a problem. But that's really rare. That's a huge defect, and that usually only happens with multiple recurrent dislocations over years. But pretty much everyone who will have a CT scan or an MRI will have a Hill-Sachs lesion. That's just part of the pathology. Sure.
Okay. And just a brief call out to ACJ dislocations.
Yeah, that's a good one because it's really common. So there's different grades. So if you think someone's got an AC dislocation, the radiologist will usually do it, but you need both sides, and there's particular views where the patient holds a little weight in their hands, so it stresses the AC joint. So you need AC joint stress views. If the clavicle lines up with the acromion, then that's normal. One would consider fixing it if it's 100% displaced. So there's grading where it's less than 50%, 50%, more than 100%. If it's more than 100% in manual workers, then that can be problematic because if they rest things on their shoulder, it's uncomfortable and sore. But if it's just the weekend warrior at footy and it's 100% displaced and they're a desk worker, for example, and there's no real reason to fix that. It's largely just a cosmetic problem. And there are some rare AC joint dislocations which probably wouldn't leave the emergency department because they're associated with other injuries that need to be fixed. But if it's 100% displaced in a manual worker, it's reasonable to fix it, but they're off work for 3 months.
Okay. There's a few jokes going on there about weightlifters getting chronic AC joint dislocations. Maybe after the Olympics.
Yeah, maybe.
Well, I had a quick question for you about any exciting new advances in orthopedics. The reverse shoulder looks exciting. I've been around for a while, but I guess there are any new things going on there for you?
Probably in shoulder stuff, there's some biologic treatments around chronic cuff tears in young patients. So the really difficult problem is the 45-year-old who's had who's been a manual worker, had a cuff tear years ago, never done anything about it, and now has reached a point where they can't work. So they've got a big, large irreparable cuff tear. In the past, that's largely been very little to offer patients, but there are now biologic patches which can be sewn in over the cuff, which promote some tissue growth, which in young patients with chronic cuff tears can confer good pain relief and good function. The other things probably around hip and knee replacements and the use of technology. There's still not a lot of evidence to say much of this makes any difference, but there's something that's come out of the US recently that says that navigation of knee replacements is probably better than no navigation. So navigation has been around for a long time, probably 10 plus years. But it's sort of been superseded or overtaken by robots, which are popular for largely no clinical benefit. And the other thing is called patient-specific instrumentation, where the knee's imaged with CT scans or MRIs, and then jigs are built for that one patient. So it's not so much exciting, but it's some more evidence coming out to say what of that technology actually makes a difference. And it's probably the older style of technology, which has been around for a while, called navigation, which a lot of people don't use anymore because it's trendier or whatever to use. Robots is the flavour of the month still. But there's probably going to be some evidence to say patient-specific instruments, which are more closely related to navigation, are going to be a good thing as well. And that sort of ties in with what the Joint Registry is doing. So the Australian Joint Registry is an incredible piece of perseverance and data collection. So there's 1.5 million joints registered in Australia now between hips, knees, and shoulders. And that's where one of those little graphs came from with, the reverse shoulder replacement. But you can find out largely anything about any implant and how it performs in Australia, but it's going to be linked to technology. So those things that I've talked about and patient-reported outcomes. So that will give us great data on what is working in hip and knee replacements.
Big data.
That's
data. Really interesting.
Yeah, it is.
Okay, well we're gonna move into the wrap up now. So
yep.
We'll just quickly make sure people know how to refer to you. that should be on the next slide. So,
yeah, so I take all my referrals through Lismore. I'm very amenable to taking phone calls about patients, whether they're my patients or new patients, to troubleshoot. I did want to mention that it's at the moment it's largely Luke Henschke, myself, and John Myson who do shoulder stuff. John, as I'm sure you guys know, is sort of moving away from the public stuff, but we're all still doing public and private shoulders as it stands at the moment.
Yep, that's good to know. And and we're a big fan of electronic referrals at Nordocs. You accept electronic referrals?
Yeah, absolutely. Medical Objects seems to be the one that we get most referrals through, but I think our software platform accepts referrals from various platforms as well.
Great. Fantastic. Well, that's a big thank you from us and your family, by the looks of it, for dragging you away for an hour.
No, that's all good.
Yeah. So that's great, Shane. It was I really learnt something tonight. So very, very helpful.
Oh, great. Well, thanks for inviting me. I really enjoyed it too. Thanks, Pete.
Great. No worries, mate. So stick around. You turn your camera off, but stick around. I'll have a quick chat afterwards. But
okay, sounds good.
Yep. We'll move into the next slide. So just a quick reminder about our website. On the website, there's a web page directing you to previous webinars, previous recordings, and this one will be up there soon. And of course, the next webinar. We now have an email address. Please send that to your colleagues if you want to get emailed about future events. And we also have a Facebook page. And at the conclusion of this webinar, you'll be sent a survey, and if you put your name at the end of the survey, you'll also receive a certificate which you can use for CPD. And you can also register for the next webinar, which will be in 4 weeks' time, and we're going to go in a slightly different direction. We're going to talk about ADHD in adults with Dr. Hugh Morgan. So thank you so much for joining us tonight, and we'll see you all again in 4 weeks.